Hey, future nurses, welcome back to Discussions with Dr. G. I'm Dr. G, and if you're here, you probably want meds to work for your patients and maybe, just maybe, not kill anyone with a statin. Today we're talking pharmacogenetics. Hey, don't run away. It's just a fancy word for how our genes mess with drugs. Basically, pharmacogenetics looks at genetic differences and how they influence the way folks respond to meds. Not everyone turns codeine into morphine the same way, and as nurses, knowing who turns what into what can save you a lot of headaches or lawsuits, honestly. Here's where it gets spicy. The cytochrome P450 system, or CYP450, if you want to sound like you know what you're talking about at interdisciplinary rounds. This enzyme system is like the bouncer at the drug metabolism club, except depending on your genetic variant, sometimes the bouncer lets too many people in, sometimes not enough, and sometimes the club gets shut down by a party crasher, like grapefruit juice. No joke. Grapefruit juice blocks CYP3A4, so drugs like statins or some calcium channel blockers can build up. Don't even get me started on the time I had two patients on the same dose of amlodipine. One felt nothing, the other had more swelling than my cat after a bee sting. And this classic codeine story. Some people, ultra-rapid metabolizers, turn codeine into morphine so fast they're basically getting hit by a truck. Others, poor metabolizers, barely get any effect, so you're sitting there charting complains of pain for the 13th time. Once, same shift, two patients, same med. One is off in la la land, and the other is miserable. I'm walking around like, what is happening? Am I losing it or what? And then a doc cracks a grapefruit juice jokes, and I realized, oh my gosh, we're actually talking about genetics right now, not fruit snacks. Anyway, how do we wrangle this knowledge in real life? Basically, pharmacogenetic, PE6, testing lets us peek at a person's metabolism roadmap before we even slap on a med patch or pass that pill cup. Adjusting doses based on genotype can totally change outcomes. Let me throw out a classic. Malignant hyperthermia risk. If you've ever read those horror stories about anesthesia gone wrong, sometimes it was the result of an underlying genetic variant that nobody knew about. So a little PGX data up front and boom, life saved. No drama. Or take antidepressants. You know the dance. Start low, go slow, cross your fingers, hope nobody's serotonin takes a nosedive. With PGX, maybe we can quit the trial and error kabuki and actually target therapy. Think about the cost, financially and emotionally, of getting it wrong 5 times before we get it right. Individualized care means less time wrestling side effects, more time, actually doing nursing and less apologizing to patients. That's a win. Now, somebody's going to ask, but Dr. G, how do we fit this into workflow? Well, let's be honest. Nobody's giving us extra time in the shift, but collaboration is key. Nurses are on the front lines. We notice when pain meds don't work or when someone gets weird side effects right away. Share that intel with the provider and ask if PGX testing makes sense. Oh, and tip, keep a list of good resources. I'm always checking Clinical Pharmacogenetics Implementation Consortium guidelines. And yeah, I actually read FDA drug labels now. Weird nurse confessions. Now let's talk about the stuff that keeps us up at night. Ethics and all the legal spaghetti. Whenever you're dealing with genetic data, privacy is a big deal. Health Insurance Portability and Accountability Act, HIPAA, and Genetic Information Non-Discrimination Act, GINA, allegedly have our backs, but you still got to explain to patients exactly what happens with their info, who sees test results, how it might impact insurance. It's not just clicking consent on a screen, okay? Equity is another monster. PGX testing can be pricey, and honestly, a lot of the research behind it really favors certain populations. So it's our job to be the annoying question askers. Are we offering this to everyone? Are we explaining it in a way that families actually understand, not just, did you read the pamphlet? Had a family once, super skeptical, and I basically had to turn into a genetics TED Talk on the night shift. Sometimes advocacy means translating jargon. Other times it means chasing down social work to find programs that help cover testing costs. PGX is here, and nurses are the ones who make sure it works for actual humans, not just genetic geeks. We got to keep learning, keep questioning, and find ways to make this stuff work even at the bedside, not just in the lab. Thanks for hanging out and nerding out. Next time, we'll dig even deeper into pharmacotherapeutics for nursing. Until then, keep fighting the grapefruit juice menace, and I'll catch you next time.